Well, welcome everybody to this AHA session on coronary inflammation, shaping the future of long-term cardiovascular risk reduction. My name is Paul Ridker. I have the honor of being the first presenter here. I'm joined by my co-chair and friend, Charis Antionadis from Oxford. And this session has been put together in purpose in two different parts. I'm going to cover some general issues about inflammatory biomarkers and inflammatory screening to sort of set the clinical stage for what's possible. We'll talk a little bit about HSCRP and my general belief, as many in the audience I know share that belief, that the time has come for a real marriage, a true marriage between biomarkers and imaging. And then Charis is going to talk about a particular kind of imaging and a way of actually thinking about, can we actually image inflammation in a way that's clinically useful to us? I want to thank our sponsor, which is Caristo Diagnostics, for the event today. And we're just going to jump right into this because we decided that we'd like to get through the formal content fairly quickly, and then we're very open to taking as many questions as we can during this session. So, my half of this is going to be a discussion about inflammation, CRP, and opportunities for prevention and treatment. But the real subcontext here is something that's new, which is we have imaging tests, traditionally like coronary artery calcium, which are clearly our best predictor of cardiovascular risk if all you wanted to know was, are you at risk or not? Patient has the disease, doesn't have the disease. But I've always argued in that setting that there's more to know than that. What do we want to actually treat with? So if imaging can tell us who's at risk, I need some biomarkers to tell me, well, why are they at risk? And what are my targets for therapy going to be? And bringing these two worlds together is what I want to talk about today. I have a variety of conflicts. Take it or leave it. So this field, and Peter Libby and John Deanfield are both in the front row, which is great because they've been involved in this field for as long as we have and contributed in many different ways to this kind of thinking. Arthritis, psoriasis, lupus, inflammatory bowel disease, all the chronic autoimmune diseases all have elevated cardiovascular risk. And the tension has been, can we find biomarkers that can tell us who's at risk, and can we actually alter the various pathways that drive that risk? And the right-hand side of the slide is a cartoon of the NLRP3 to IL-1 to IL-6 pathway that has really changed the way we think about this disease. I'm going to talk about this from a very clinical perspective. There's quite a few vascular biologists in the room here who could give a superb discussion about this from a fundamental bench perspective. But this is the paper we published all the way back in 1997 saying, look, inflammation precedes the onset of acute ischemia. That may seem obvious today, but at the time it was very, very important because up until then, the ideas about this field were largely driven by patients arriving with acute ischemia had a pro-inflammatory milieu afterwards. That's a very important issue, and it's also important for therapy, but it didn't establish whether or not the inflammation was there before the onset of disease. That's what this paper from 1997 did for us, and because of the anti-inflammatory aspects of aspirin began this whole journey. I want to remind the audience, though, that we also knew more than 20 years ago that this inflammatory process was extremely important for other disorders. I just show here the papers from my colleague Aruna Pradhan and Howie Sesso. These were the first demonstrations that inflammatory cytokines like IL-6 and the marker CRP were also predictive of incident type 2 diabetes and incident hypertension. I show this today because some of you who were at the sessions this morning heard about the tirzepatide data in the SUMMIT trial talking about how GLP-1s are very useful for lowering inflammation. That's probably true. Clearly it lowers CRP. But all these ideas have been with us now for a long time in terms of bringing together issues about metabolic syndrome and inflammation into one place. The high sensitivity CRP test has been with us since, 20 plus years now. Levels less than 1 to 3, greater than 3 milligrams per liter still today are telling us about lower risk, moderate risk, higher risk. Our guidelines now nationally incorporate this in the US as a tiebreaker for who you might want to give statin therapy to. In Europe, universal screening is now there. And I want to argue that we should have universal screening here in the United States. I want to make that argument on two different kinds of settings. This is the secondary prevention data that we presented now 2 years ago, 3 big clinical trials that you know well, prominent, reduce it, and strength, all secondary prevention, all on statin therapy. And the strongest predictor of another event was not the LDL cholesterol that, of course, all of us aggressively lower, but the strongest predictor was actually the high sensitivity CRP shown in black. So from across the room, you can tell that we have to address this inflammation, and I would argue, and I have argued for years, we should have universal screening for hsCRP and secondary prevention because these data clearly tell us there's an unmet clinical need. Now, when those data first came out, some people said, well, Paul, everybody's on a statin. You showed years ago that statins lower CRP. Is that somehow a bias against LDL? And I said, look, I'm an incredibly aggressive LDL-lowering physician, but let's look at patients who are contemporary, who are not on a statin. That's the bottom half of the slide. It comes from the bempedoic acid trial. And again, it's the same observation. In contemporary care, secondary prevention, not taking a statin, CRP is outperforming LDL. Again, the idea here is let's measure inflammation and figure out what to do with it. But the real issue in these data has been this notion that we are driving LDL levels lower and lower. That's a very good thing to do. But look at these data from a different perspective. This is the same thing, statin treated, statin not treated, 50,000 patients, 4 groups. The far left-hand group is an LDL below 70 in secondary prevention, below 130 in primary prevention, with a low CRP. That's the lowest risk group. The far right-hand side is the highest risk group. That's high LDL, high CRP. All that's fine. But the second column in from the right should give you pause, because that's the group with an LDL less than 70 and a CRP above 2, or in the bottom half, less than 130 and a CRP above 2, suggesting that even when we've given the patients a statin, the problem, the biggest problem, is the residual inflammatory risk. Again, please lower the LDL as much as you possibly can. The message is think also about the inflammation. So I want to emphasize for a few minutes data that we presented at the ESC in London that's coming out. It was published electronically in New England Journal. It's coming out in print in a few weeks. To give you a sense of what's going on here, many people have continued to say, well, hsCRP is variable. I'm not so sure it really works. Let me convince you that it works very, very well. My colleague Julie Beering and I have run a cohort called the Women's Health Study funded by the NHLBI for over 30 years. And 30 years ago, we took a random blood draw, put it in liquid nitrogen and froze it, and measured 3 things: LDL cholesterol, hsCRP, and Lp(a). This is the data on CRP predicting risk at 10 years, at 20 years, and at 30 years. That's quite remarkable. If this is so variable and so random, why are we doing such a good job long-term about this biomarker? But now let me compare it to LDL cholesterol on the left, also an excellent predictor of risk and obviously a major target for therapy. But you notice quite quickly that the spread in predictive value for the CRP data on the right is actually greater than the spread for LDL cholesterol on the left. Obviously, we're going to measure LDL. The question is, in primary prevention, should we also be universally screening for CRP? That's for major coronary events. This is for ischemic stroke. So again, LDL predicts stroke. We know that statins can reduce stroke. Lipid lowering reduces stroke. Notice again, the spread for the CRP is, if anything, greater than the spread for LDL cholesterol. But many of our colleagues are still not measuring inflammation on a routine basis. Jupiter trial was discussed earlier today in many different sessions. Just a reminder, if your CRP was high and the LDL was below the treatment targets, phenomenal benefit from being on a statin. Clear evidence that these drugs are excellent lipid-lowering drugs with additional anti-inflammatory properties. But I just want to remind you, 44% reduction in the primary endpoint, 60% reductions in MI, nearly half reductions in stroke. We should be having universal screening, because if we only screen for LDL, we're going to miss the opportunity for all these patients. And this data was published in 2008. Our guidelines need to change to recognize the biology that many of you contribute to. Cantos, again, Peter is in the front row here. Cantos said, look, what about targeting inflammation directly? Can we actually prove the inflammation hypothesis of atherothrombosis? Cantos says we're going to go into secondary prevention, elevated hsCRP, 3 different doses of canakinumab, a novel interleukin-1 beta inhibitor, And what do we get? We get dose-dependent reductions in CRP, we get dose-dependent reductions in IL-6, and we get a 15 to 17% reduction at the 2 higher doses of canakinumab for MACE and MACE+. And again, just to remind people, when we presented these data at the ESC in 2017, so already 7 years ago, this was the same year that the PCSK9 trials came out. Now, the PCSK9 trials are very effective drugs. They also lower risk by 15 to 17%. But to someone really interested in inflammation biology, the fact that the very first clinical trial of inflammation inhibition matched a very aggressive LDL approach was extremely reassuring to us, and that's where this story sort of begins. Now, some controversy going on at this meeting. We have 2 clinical trials for colchicine, actually 3, but I'll just review the placebo-controlled ones. The first was the LODOCO-2, the second was the LODOCO-2 trial, which is more like CANTOS, chronic atherosclerosis, 5,522 patients with prior atherosclerotic disease, high risk, again, quality care, virtually all on statins, and a 31% reduction in risk of the major adverse cardiovascular events. Quite provocative, quite interesting. Jean-Claude Tardif's study, also published in the New England Journal of Medicine, also roughly 5,000 patients with an MI in the last 30 days. So again, in my mind, this is essentially stable atherosclerosis. These patients have all been discharged from the hospital. A 23% reduction in risk. Again, virtually everyone on statin therapy. And interestingly, and I think this is reasonable, a small increased risk of pneumonia. One would anticipate some adverse events that are small when giving an anti-inflammatory approach. So far, so good. But recently at the TCT meetings, we saw data that might appear at first glance to be contradictory to this. This was patients from the Clear Synergy trial. Now remember, this is a 2x2 factorial trial. So at TCT, Dr. Jolly and his colleagues presented the colchicine half. Tomorrow morning at this meeting, they'll be presenting the spironolactone half. The colchicine half surprised a lot of people. It was a completely neutral study done in a setting of STEMI and everolimus stents. And I'm a clinical trialist who says all clinical trials are correct unto themselves. I think all these studies are correct. So what's different about them, and why might one be a very different outcome than another? We haven't seen the manuscripts yet, so we can only speculate. But one of the issues has to do with one of those trials was done during COVID, at a time when getting through things was very difficult. So let's just be open-minded about it. Let's wait for this spironolactone trial tomorrow. If it's positive, okay, then probably the data are not confounded by COVID. But let's see what happens, and if it's neutral, we'll have to sort of think this through. But the IL-6 part of this is really interesting, because we showed in CANTOS that the on-treatment CRP, the on-treatment IL-6 were really driving the ultimate benefit of being on these drugs. That was a really interesting observation. It parallels what we know about LDL cholesterol. The greater the LDL reduction, the greater the benefit. With blood pressure reduction, you have to get it down to actually benefit. And so here for the vascular biologist, the fact that getting the IL-6 down and getting the CRP down mattered is a big deal. We did a secondary trial with a drug called ziltivekimab, which is a monoclonal antibody now targeting interleukin-6 ligand rather than IL-1 beta with canakinumab. The data have been published a couple of years ago. You can look at the waterfall plots and get a sense that almost all patients receiving this particular drug get a large reduction in their CRP levels, so they would all be responders, at least based on the prior study. So the objective here is, well, okay, can we now go down that pathway to see what happens? Well, at this meeting, there's a lot of discussions going on. We have an investigator meeting this evening for 3 different trials. One is called ZEUS, that's fully enrolled. That's patients with chronic atherosclerosis, chronic kidney disease, a group I really should not give colchicine to. Colchicine is metabolized by the liver and the kidney. Hermes is a trial in HFpEF, very interesting study about whether or not we can alter the inflammatory milieu of HFpEF. And the Artemis trial, just up and running now, looking at acute coronary ischemia. Big thanks to Novo Nordisk, actually, for sponsoring all these trials to actually take this whole idea into clinical practice. So before handing this over to Harris, CRP, a biomarker of silent vascular inflammation, it's at least as strong a predictor of future cardiovascular events as is LDL cholesterol. We should have universal guidelines, in my mind, in both primary and secondary prevention, along with Lp(a) screening. If my patient has any one of those 3 that's elevated, I want to target my therapies in that direction. While imaging tests such as coronary artery calcium can tell me very well who to treat, measurement of these biomarkers can tell us what to treat with. We need to marry these two pieces together. And the reality is that we won't treat what we don't measure. We need the marriage between imaging and biomarkers to provide the greatest benefit for our patients. Our guidelines have to get there, and the sooner they do, the sooner our patients are better off. I think the time has come for targeted anti-inflammatory therapy. I know that many of you, probably because you're at the symposium, might agree with that. I want to emphasize the most important biologic issue. Inflammation, inhibition, and lipid lowering are not in conflict. These are synergistic therapies. A future would be very bright if we had aggressive lipid lowering and anti-inflammatory therapies. And last, but partly to introduce Harris, inflammation imaging using CCTA may give us a novel way of thinking not just about plaque characteristics and about change in plaque over time, but perhaps by looking at perivascular fat and the fat attenuation index, perhaps a way to actually image this very inflammatory response. So Harris, I'm going to end there and let you explain to us the new data we have for actually measuring residual inflammation from routine CCTA by analyzing perivascular fat. So Harris, thank you.
Thank you, Paul. Thank you, everybody, for joining us today. These are my disclosures, the most significant of which is that I'm founder and non-executive director of Cardiovascular Diagnostics, who sponsored this session, one of the founders. Now, in order to understand prevention, in order to understand who needs to be treated with what, we need to look into the natural history of cardiovascular disease, of atherosclerosis, and you'll see that approximately 6.5% of the population will develop at some point in their life obstructive coronary artery disease. They will have angina, chest pain, and they will seek advice from a doctor. However, we know now, and these are results from the recent orphan study, and I will come back to this study later in my talk, that 2/3 of the individuals that have imaging for coronary artery disease essentially do not have obstructive disease, and they are the source of the majority of heart attacks. 60% of the heart attacks happen among individuals who do not have obstructive coronary artery disease, which means that we have a window of opportunity before we start having any symptoms, any chest pain, any angina, to go early, identify these individuals, and treat them. Calcium score is what is used clinically in the US at least today, but let's not forget that calcium score flax disease that is stable, flax calcification, and it doesn't identify the vulnerable plaques. The key driver of atherosclerosis, as Paul has mentioned in his talk, is actually inflammation, because this is a trigger of the disease, and it also leads to destabilization of plaques and plaque rupture events. Indeed, inflammation now is widely accepted as a major therapeutic target. All the positive trials that Paul has mentioned are there. The results are striking. This is why the ESC guidelines already from 2021 introduced colchicine as a way to treat coronary inflammation for cardiovascular risk reduction. And the FDA gave clearance with cardiovascular reduction label in 2023 to colchicine. However, as Paul has mentioned, there are also some negative trials. We have the CIRT that was run by the Harvard team, which probably used the wrong drug. It didn't really change high sensitivity CRP when we used methotrexate, and it didn't change events in the CIRT trial. And then we have the clear synergy trial, again with colchicine, very recently published, that was during the acute phase of MI, and this was a negative study. So can we really get better effect sizes and better results with anti-inflammatory treatments if we become smarter in the way we select the patients to treat with anti-inflammatory agents instead of treating everybody blanket? This is exactly what Paul has mentioned in his talk about high sensitivity CRP and the other plasma biomarkers. So you can use plasma biomarkers to screen patients, to identify the high-risk individuals that need to be treated with anti-inflammatory agents. However, as we all know, these inflammatory biomarkers are not specific. They are sensitive, but they are not specific because your IL-6, your CRP can go up if you have any kind of infection, if you have lung infection, if you have arthritis, if you have, it doesn't necessarily mean that you have vascular inflammation. So we need tools to narrow down to those individuals who do have inflammation inside the coronary arteries. We can use plasma biomarkers to pre-screen individuals, and then we need to come up with more sophisticated methods to identify the individuals at risk that need to be treated. A few years ago, we discovered that in my lab in Oxford, that when you have increased inflammation in your coronary arteries, then the inflamed artery secretes inflammatory molecules in the perivascular space, and you have these lipolysis, you have changes in the texture and composition of perivascular fat around the arteries, and this could be a surrogate of inflammation inside the vascular wall. In coronary CT angiography, you get these black and white images, so you cannot really tell by looking at these images which artery is inflamed and which is not. We develop a method that is called fat attenuation indexing that brings this information from perivascular space to the surface, and you can see that if you have inflammation in the vessel, you get a red color. If you get a yellow color around the coronary artery, then it means that you do not have inflammation or is very low inflammation. If you get the blue color, then what I say is blue is death. Blue is lipolysis, severe lipolysis, and this is what you can see in this highly inflamed coronary artery here. This is an image from a patient with STEMI that was scanned recently in our lab in Oxford. This is how a culprit lesion looks like when you screen along the lesion by using this approach. You get this red color accumulating around the inflamed area of the artery. But if this approach, this fat attenuation index, indeed flags inflammation, it should predict events because we know that inflammation is a key driver of cardiac events. And indeed, in the CRISCT study that we published a few years ago, that was done in 4,000 patients, 2,000 from Germany, 2,000 from US, it became very clear that if you have inflamed coronary arteries identified by using the fat attenuation index, you have 5 to 9 times higher risk for a fatal cardiac event. After these original findings, we then tried to standardize this approach and make it clinically useful. Any measurement that relies on Hansfield units, on attenuation readings on CT, is prone to variability, technical variability, based on the scanner, based on the reconstruction algorithms, based on individual patient anatomical characteristics. And this is why we developed the fat attenuation index score, the FI score, which is a standardized metric of coronary inflammation. And this is measured in any of the 3 coronary arteries. It's interpreted in age and sex-specific nomograms. And this is what has received the label as an imaging biomarker of coronary inflammation in Europe and in the UK. Now, this is exactly the importance of standardization for measuring this inflammation by using CT in the coronary arteries. This is what was highlighted in a recent clinical consensus statement from the European Society of Cardiology that made it clear that we need to be very careful in how we measure attenuation around arteries in order to study inflammation. We need to have a standardized method that is regulatory cleared in order to get clinically meaningful information from this type of analysis. Of course, when you have a new biomarker, there is always a challenge. Is it reproducible? Is it widely applicable? Is it generalizable? This is exactly what we aim to test in the Orphan study. Orphan study is by far the world's largest prospective outcome study with coronary CT angiography. It aims to include 250,000 individuals with coronary CT angiograms linked with lifelong outcomes data. We now have enrolled 175,000 patients, and the first results were published in the last a few months ago. Now, looking into the UK population of the Orphan study, we quantified coronary inflammation by using the FI score, and you can see that if you belong into the top 25% of the distribution of inflammation in any of the 3 coronary arteries, then you have 20 times higher risk for a fatal cardiac event and nearly 7 times higher risk for a non-fatal. If now you focus on that very interesting population without obstructive CAD, then you'll see that, again, high inflammation identifies individuals with 10 times higher risk to die from a cardiac event. These are individuals that are sent home reassured that their chest pain, the reason why they had the CT angiography was chest pain originally, we reassure them that the chest pain is not behind the symptoms. But there is an even more interesting category of individuals, those who do not have any visible atherosclerosis, zero calcium score, or if they have a flake of calcium that will not classify them as cataracts more than 1. Again, if you measure coronary inflammation in these individuals and you follow them up for a decade, you will see that the people with the high inflammation develop disease, and the curves continue to diverge many, many years later. And this is independent from where you measure inflammation. In the LAD, in the circumflex, in the RCA, the result is very, very similar. No matter where you measure it, you get this striking predictive value. Now, how is it possible in the absence of plaque to have heart attacks? Well, it is possible because even if you do not see, this is from a post-mortem study, this is unpublished data, even if you do not see atherosclerotic plaques, it doesn't mean that there is no atherosclerosis. There is at least intima hyperplasia in many of these individuals, and then when you identify high inflammation by using the fat attenuation index score, then you have at least fatty streaks in these coronary arteries, and these are coronary arteries from a post-mortem study. Now, there is also an add-on effect of the number of inflamed coronary arteries on risk prediction. If you have none of the 3 coronary arteries inflamed, then you are on this green line, and you can see that essentially you develop no events. If you have 1 inflamed artery, then you go on the blue line. If you have 2 and then 3, you can see how risk adds up. And this is for fatal cardiac events, and a very similar finding was also observed for MACE, for fatal and non-fatal together. So we may actually start thinking now about the power of zero inflammation. We have been talking about the power of zero calcium. Now that's another concept that we could potentially consider. Of course, in clinical practice, we always treat our patients based on risk. This is what the guidelines tell us. They tell us if the risk is above a certain level, then you start starting treatment, then you can consider additional treatments, etc. This is exactly what we try to develop by using artificial intelligence. So we use an AI model to integrate all the information available from the coronary CT angiogram, information about the extent of atherosclerosis, of plaque, information about inflammation, and the risk factors of the patient in order to develop what we call the AI risk model. That's a prognostic model that quantifies the absolute risk of the individual for a fatal cardiac event over the next decade. It was first developed in the US population, it was then validated in Germany, and now we tested it. After it was locked as a locked medical device, we tested it in a completely fresh population in the UK in the orphan study. And this was 4 years after it was originally developed, and this is the result. You can see that the area under the curve for predicting fatal cardiac events over the next decade was 0.844, and we have already reached that level by simply measuring inflammation in any of the 3 coronary arteries by using the phi score in any of them. So this is a striking prognostic value just from the pictures without taking into account the risk factors of the patient, etc. Now, this model creates these theoretical risk prediction curves. So these are the predicted events in the population based on the AI risk model. We have the patients with low, medium inflammation with the green, patients with high and very high inflammation. After we made this prediction, we then opened the labels and looked at the true events. And these are the true events. The solid lines are the true events, the dotted lines are the predicted events. Essentially, you end up predicting nearly every single event that happened over a decade after this AI model made the predictions. If you focus now in individuals without obstructive CAD, which are even more interesting, you get these curves. you open the labels and you see that the prediction is very similar. You have very, very, very similar true events compared to the predicted events. Now, what happens to patients with obstructive CAD? These are patients who are diagnosed with obstructive CAD at the time of the scan. After that, all of these patients went to the cath lab and they had an investigation. Many of them had a PCI. You see that in the top risk group, the prediction was pretty good, very good alignment between the dotted and the solid line. What happens here? You see that the predicted events were significantly higher for at least 2.5 years after the scan compared to the true observed events in this group of patients. How can you explain this? Remember that these are the top group, the most inflamed patients. They had mostly diffuse disease. Only 35% had revascularization. In these lower categories, we had 44% revascularization, and this change here of the event rates has happened when the patient stopped dual antiplatelet therapy. So you can see that the events are not happening as predicted for 2 years. After 2 years, when these patients start dropping the antiplatelet therapy, the dual antiplatelet therapy, you see that the events jump back up and they go exactly there where they were originally predicted to be. And this tells something also about the recent colchicine trials. Now, we have calcium score. Why do we need inflammation phi score? Well, we need it because the prediction of risk is completely independent from calcium score. If you look into the additive, the prognostic value on top of calcium score, you can see that you can achieve area under the curve that approaches 0.9 if you build on top of calcium score the inflammation. And calcium score, when you treat the patients with statins, essentially goes sky high. You induce calcification because you stabilize the atherosclerotic plaques. However, with inflammation, you track risk in a much more accurate way. Risk goes up, inflammation goes up. When you start treating the individuals with statins, as the risk comes down, inflammation comes down, and calcium goes up. This tells you exactly how these relationships are expected to play out when you treat your patients with statins. How to treat now coronary inflammation? As I mentioned, statin treatment is a very effective way to reduce the fat attenuation index score. There are several studies showing that. Biologics like anti-TNF-alpha, anti-IL-12-23, especially in patients with psoriasis with high inflammation. A recent clinical trial with ortiquumab has shown that if you treat with a monoclonal antibody against oxidized LDL, you reduce inflammation. And more importantly, both with statins and also with ortiquumab, you also reduce the calculated 10-year risk for fatal cardiac events in these individuals. So it's not only inflammation that you treat, but you treat the risk related with inflammation. This technology is now being used clinically in the NHS. The first 5 hospitals are now implementing it, and they make decisions based on inflammation in the coronary arteries of patients who have coronary CT angiograms as part of clinical care. From the first results that are part of a large audit that is taking place in the UK now in these hospitals, 45% of the patients actually change management. So the clinicians report that they change the treatment of 45% of their patients based on this information. And there is this model saying that they expect to see 11% less heart attacks and 12% less cardiac deaths in those who receive this intervention. And if you look into the health economic impact of implementing this technology in the NHS in the UK, you will see that the price of COLI, the ICER, the incremental cost effectiveness ratio, is not more than £3,500, which means that it's way, way below the £20,000 mark that is identified as the threshold for cost effectiveness in the UK. Is it prime time now to diagnose and treat inflammation? I believe yes, and I'm sure that Paul agrees with this. Inflammation is a therapeutic target. We can measure coronary inflammation by using imaging, and the inflammatory risk is measurable as well by using AI models like the AI risk model And these interventions, these diagnostics that lead to these interventions are cost-effective and are being used clinically in Europe and in the UK. I will leave it here, and I'm happy to take questions.
Doris, thank you so much. I actually want to begin by saying please come up to the microphone and ask questions. We'd rather do this live if we can. But I would congratulate you and your colleagues on the recent Lancet publication in Orphan. I think it really did, for me, change the likelihood that this will be a useful clinical test. I think I was particularly impressed, not just by the fact that those with obstructive and non-obstructive disease, that you could use this fat attenuation index to tell us about risk. I was very impressed with the CAS-RAD 01 group. I mean, that's sort of saying, okay, that to me is primary prevention. That says they would have been missed by a CAC scan in a typical way of thinking about it, and yet you've found something here that says, aha, these patients are still at risk. So I'm very optimistic about that. I think that the field will need some randomized trial data. I think that ultimately we have to sort of say, okay, if we're going to put this into practice, how do we actually use this within the context of randomized drug trials to figure out, will it tell us what's better or not? I actually see Ron Blankstein in the front row here. There's a lot of people who are probably thinking about this new NIH initiative to sort of figure out, can we use CCTA, potentially perivascular fat? But one thing just technically I want to ask you is, can you just explain to those who don't already know, what's different between what you're talking about, FAI, versus other measures of perivascular fat? How does that play out?
Yeah, so that's a very good question. So when we first described the method back in 2018, we described it as a measurement of perivascular attenuation. When we try to generalize it, we've noticed that if you go to a different scanner, different settings, then this falls apart. It's not reproducible. If you just measure attenuation in Huntsville units, then that gives you, at a population level, some prediction, hazard ratios around 2, 2.5, but when you go to the individual patient, it doesn't seem to work that well. And when you change scanners, when you go to a different institution and you try to mix the results, it doesn't work. This is why when we try to clear this as a medical device, there was a lot of discussion about how do you standardize it to make it clinically useful. And that's why we put a lot of effort, because of 3 years of development, in order to create all these conversion factors that allow you to measure the phi score, which is without units. It's not in Huntsville units anymore, but that's the one that received the label in Europe as a biomarker inflammation. It's not expressed in Huntsville units. It's expressed in absolute, it's an absolute number, it's a score.
So again, I want to encourage people to feel free to come up to the microphone. We'd like to hear your questions about the whole issue of inflammation inhibition and inflammation imaging. And Harris, while we're waiting for that, I'll let me ask another question, which is even in the setting, so I am impressed with what you've done with the FAI score. It certainly is working well, which is very impressive. But even then, wouldn't it matter to use the same scanner twice in the same patient over time if you were trying to look longitudinally? I mean, would I worry at my own institution that I want to have the same parameters, the same scanning?
Yeah, this is a very, again, this is one of the biggest weaknesses of all imaging tests. Because when you change the technology, you potentially change the absolute values that are generated by the actual machine, the images. And this is why you need to use a standardized measurement that takes into account this variability. And this is, when you have a CRP assay, in order to be clinically applicable, it should not matter if you measure it on an Abbott kit or or whatever company, right? You don't care. You don't really ask what assay did the lab use to generate my CRP measurement. So this is exactly where we need to go with CT and with imaging. And this is a first effort, a first attempt to do this by using the phi score, and I'm sure that we'll do something very similar with plaque.
Yeah, I'm smiling because you have no idea how much effort went into getting all those assays for CRP to actually work correctly with each other. Yeah, a question from the audience.
Two great talks. I really kind of enjoyed both of them, and impressed with how far out you can predict events, 10 or 30 years with imaging or biomarkers, respectively. Do the markers of imaging markers of inflammation correlate with biomarkers of inflammation as well? So CRP or IL-6 or IL-1, things like that.
Again, a very good question. So there is a paper that we are preparing with, Peter and John and Paul. Just be patient.
It's a really important question for a number of reasons. My guess is no matter how good the correlation is, we're going to end up doing both anyway. First of all, the biomarkers are really inexpensive, and as this becomes less expensive, I think the financial part of this will become not the relevant question anymore. Because I think at the end of the day, we as cardiologists want to know several different things. I want to know who's a high-risk patient, who's a low-risk patient. Imaging is clearly very effective for that. But I also want to know what am I going to recommend to my patient that's more than just diet, exercise, and smoking cessation. If we only were in a lipid-lowering world, where we've been for 45 years, this was a moot question. But we're well past that. We're in a world now where we're going to be treating different aspects of this. Some patients should be on very aggressive lipid lowering. Some patients should clearly be on second and third LDL lowering drugs. Other patients probably don't need more than that statin. Some patients are going to need clearly anti-inflammatory therapies. With any luck, the Lp(a) trials are going to work. With any luck, some of the other trials looking at HDL mimetics are going to work. And we'll have different armamentariums to treat our patients. And we're going to need to have the biomarkers to say, this piece of biology is different for this patient, and this patient. The imaging is going to help us to say, these are the patients we should really worry about. And I think bringing those together is what I hope becomes the basis for preventive cardiology, also in secondary prevention. But that's a bias I have about the field. Yeah.
Thank you again, both, for those great talks. When I think about pericoronary fat, I'm thinking of like visceral, that kind of falls under the umbrella of visceral fat. It's not uncommon that when we're reading like echocardiograms that we see, a comment on the presence or absence of a pericardial fat pad. Is there any relation between that and pericoronary fat or pericoronary fat attenuation/inflammation?
Yeah, it's actually a great question. You can go back almost 30 years to some original studies done by echocardiographers working in Rome with Attilio Mazzari and his inflammation group, showing that the amount of pericardial fat did in fact influence the level of some of these cytokines. And sort of analogous to what's going on with the perivascular fat, it was around the heart and seemed to have a greater effect than fat that was in the belly. That's all true, but I don't think it's anywhere near as precise as what we're now talking about here, looking at fat on the arteries themselves. I think that would be a fair estimate.
Yeah, and let's not forget that perivascular fat exerts effects on the vessel, so it is detrimental on its own. However, it also receives signals from the vessel and changes. It remodels, and it may actually be protective under some circumstances, depending on the signals it receives from the vessel. So it's from a biological point of view, it's a crosstalk, it's a communication between the two, and it's very difficult to separate the chicken from the egg here. This is why you need this kind of sophisticated analysis that looks into the changes as you move away from the vessel, in the attenuation and the other metrics that are taken into account to quantify inflammation.
Great talk also. In orphan, did you have a lot of asymptomatic versus symptomatic patients? And was there any difference in these groups? I'm trying to see if we can use this as a marker for patients with symptoms or angina without obstructive disease.
Yeah, there was a large number of patients who are atypical symptoms, but they all had a clinical indication to have a CCTA. So they all had a reason to be in the hospital. This was not a primary prevention study in the community. There is a study that recruited individuals from the community. That's the SCAPIS registry in Sweden. And there's also SCOT-HAR2, which is also a second primary prevention study. We are working with these groups, and I hope that we'll have results on primary prevention very soon.
I would also comment that one of the reasons that in my talk I went from secondary prevention to primary prevention is because it took a long time to realize that the expression of this disease in terms of hyperlipidemia, in terms of inflammation, was equally important in both. In fact, there's a part of me that thinks it may be more important in primary prevention to actually not let the disease develop in the first place. So just as a reminder, the largest relative risk reductions ever seen in any randomized trials was Jupiter, because it was early primary prevention, and the primary prevention arm of the bempedoic acid trial. So that's two powerful signals saying, look, if we could inhibit inflammation in our 30s and 40s, now mind you, it's got to be inexpensive and safe, but if we could, why would you wait until we have extent disease when all the relative risk reductions are actually better? So in the imaging world, Orphan, which I think is a great study, by the way, is limited to the fact that doctors had to want the scan. But I think intellectually, what you've raised is exactly the case. We need to be thinking about this much earlier. And the other question came up, the reason we published those 30-year data, well, there were many reasons, but one of them was we focused on women. The women here know full well that cardiovascular disease remains underdiagnosed and undertreated in women. And if you can predict 30 years out, why would I use a ACC-AHA risk score that only tells a woman she's at risk when she's 65 or 70 years old? It just is old-fashioned. It has to stop. We have to think about measuring these things in our 30s and 40s, giving people the opportunity to actually prevent heart disease, which is what we're supposed to be doing. Waiting until the disease is out of the barn and then saying, oh, now you can have a statin. It makes no sense to me as a preventive cardiologist, and your question is exactly at that focus there. We'll take one last question before we end.
Thank you very much. Excellent discussion. I was wondering if you'd talk a little bit about the increase in MACE with the discontinuation of dual antiplatelet therapy and how antiplatelet therapy in general can play a role in inflammation.
Yeah, so that's a finding from the orphan study. That was a very, very striking change, because we have seen that in those who have PCI, after the measurement of inflammation is done, the course of events changes. And we were wondering, is it because of the stent? Is the PCI the reason why we have less events compared to what was predicted based on inflammatory risk? Or is it something else? And it seems that this suppression of events is driven primarily by the use of dual antiplatelet therapy in those who had a PCI. And when they stop it, and in the healthcare system in the UK, from the moment you have the scan, it takes a few months until you have your PCI, your angiogram, and then the PCI, and then it takes about 1.5 years after that to stop the dual antiplatelet therapy with the GP service, etc. So around the time that you stop the dual antiplatelet therapy, you have a bounce of the events that comes back up to where they were originally predicted to be based on the inflammatory risk. So this can tell us that it's not inflammation that drives the events in this early phase, and the events are suppressed primarily by dual antiplatelet therapy. Yeah.
I'd like to thank everybody for coming to this session. Thank you, Harris. Thank you to Caristo. Enjoy the rest of the AHA meeting and enjoy Chicago. Thank you.